This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Welcome to another episode of It's Not In Your Head. I'm your co-host, Justine Feitelson, here with Dr. Dan Bates. Hello, Dan.
Hey, Juz. How are you?
Very well. How are you doing today?
Very good. Very good. All right.
Another
Sacroiliac joint
procedure.
Prolo. Okay.
Yes. Keeping the procedures rolling.
Controversial to say the least. But, here we go.
It's a hot topic. Yeah. And this will be good because a lot of our
Okay. If it's a hot topic in your world, you've got to get another world. That's all I got to say.
It is. Yeah. Hey, there's other hot topics, but for the context of this podcast, this is a hot topic. Yeah. All right. Prolotherapy.
Okay, so what is prolotherapy other than it sounds like voodoo medicine? But
it sounds like voodoo. Yes.
It does sound like voodoo. Okay, so prolotherapy is the injection of a sclerosant generally into a ligament. And what you're doing in this setting is you're triggering off an inflammatory response in the hope that you'll see the laying down of collagen into that ligament. That ligament then stiffens up, you improve its integrity, and so you get better stability of the joint.
So this is in the context of ligament laxity?
This is in the context of ligament laxity. Okay. So it can be used through multiple joints. Today we're talking about sacroiliac joint dysfunction. So sacroiliac joint dysfunction is where you've got movement of the joint. How it generally presents is it presents as pain that is quite broadly located below the belt line. It will radiate across somebody's buttocks, down the lateral thighs. If you have associated pubic symphysis instability, you also get pubic symphysis and lower abdominal pain due to spasm of your lower abdominals as it tries to stabilize the pubic symphysis. Interestingly, I think that group also gets pelvic floor spasm.
I was just going to say this is great for pelvic floor dysfunction. So those would definitely go hand in hand.
Pelvic floor spasm as your pelvic floor is trying to help stabilize
hold on for dear life. Yeah.
People also get groin pain with sacroiliac joint dysfunction because the muscle at the front, your hip flexors or psoas, the old statement, doc, my hip flexors are tight, which is what I hear from the boys at footy because they've got a degree of pelvic dysfunction. And so they get secondary muscle spasm through psoas. So prolotherapy, what we are doing is we are injecting a set of ligaments at the back of the sacroiliac joint. So the ligament at the back of the sacroiliac joint is called the dorsal interosseous ligament. So that's just like, if you turn that into like normal words, that's just like the ligament at the back between two bones, literally with like said in a bit of Latin or Greek. I don't know.
Said in another language.
Yeah. And so what you're doing is you're doing an injection into those ligaments and it stimulates that inflammatory response. And then you get the laying down of collagen into that area. So there's a number of different ways to do it. So if you get online and you have a look at what you see on YouTube, it's people doing like a bunch of injections all over the place. It looks pretty crazy.
It's horrifying.
And I think what they're doing in that setting where they're doing unguided, when I mean unguided, they're just
jabbing it in there.
Yes, they're putting it in all over the place. When you're doing an unguided injection, I think you're using the Prolo in a different way. So you're using the Prolo as a neurolytic and it's altering nerve function in that setting. What we are doing is we're doing something under either X-ray guidance or CT guidance, or it can also be done under ultrasound guidance. And you are then specifically targeting the ligament. You're putting in some contrast to make sure that you're inside the ligament, and then you're injecting your sclerosant into that ligament itself. And so it's a very, very targeted approach. Interestingly, there's a number of different types of sclerosants. So we commonly
That's what I was going to ask. What is a sclerosant?
Yeah, sclerosant is something simply as 50% glucose. So we use 50% glucose that we dilute down to 25% with like a ton of local anesthetic, basically. You can also use platelet-rich plasma. So platelet-rich plasma has a different mechanism of actions. So what's happening with the glucose, it stimulates an inflammatory response. The platelet-rich plasma is actually releasing a growth factor called TGF-beta. TGF-beta acts on a set of cells called fibroblasts, and it stimulates them to lay down collagen. And so it's a different mechanism of action. The last piece is then merheuronate or something. I can't even say it. It's probably the thing that gets used in the US most. It's not...
Really?
Yeah, can't get it in Australia. Or maybe you can get it in Australia, but I can't find it. So it's not regularly used in Australia. Like for those people that are doing Prolo like myself, there's not many of us around. We're generally using 50% glucose or platelet-rich plasma. Now, if you go and look at the data, there's actually a reasonable amount of studies on prolotherapy and sacroiliac joint dysfunction. There's been randomized control trials with up to 3 years follow-up. There's one study that's done out to 15 months. And what they showed is that about 60% of patients at that 15-month mark had a 50% decrease in their pain. Right. And so once again, it's not the perfect therapy. It is not a bad therapy. And you've got to pick your patient. Like it's no use doing prolotherapy in someone who's got osteoarthritis of their sacroiliac joint because they're not unstable. I go to radio frequency for those patients that have got that going on, got an osteoarthritis.
And of those three options, the PRP is the preferred, most ideal, would you say, Dan? But Prolo is more accessible and affordable in comparison typically, or do you just look at it as it's different mechanisms?
Okay, so you raised a good couple of questions there between like affordable and accessible
and best, but realistic.
Best. Okay, so that's great.
Because I was in this boat too. I was like, I can't afford PRP, but I was like, prolotherapy, one could do business with potentially, and if the effects are similar.
So very interesting. So we're talking about the difference between Australia and US there. So in Australia,
that's why we're such a good team.
In Australia, like for me, the difference between Prolo and PRP cost-wise is like pretty much bugger all. So like we're not talking big differences in price in Australia. Now in the US, that's different. I think PRPs, you're in the $1,500 per injection range. Is that right?
Yeah.
So
either way.
what I found, so going through that process, so what I found is I've used for sacroiliac joint dysfunction, I've used both. I've used both quite extensively. My anecdotal experience is that platelet-rich plasma hurts less, works faster, theoretically should have a lower infection risk because there's white cells in it and they kill bugs.
Yeah.
However, it's not as reliable. It doesn't. I found that I've had more patients come back and just go, not that good. And I'm like, okay. The 50% glucose appears to be, it hurts more. It takes longer to work. So, but it appears to be more reliable. So as a result, my algorithm at the moment is I will start with 50% glucose. If the patient responds, great. It's generally, it's a multiple injection cycle. So we will do 3 injections, 4 to 6 weeks apart. We then review it 8 weeks after that. If the patient hasn't responded, but they're a bit better, so, okay, I'm better, I'm not good enough.
Right.
Then I will change inject date. And so then you're going to platelet-rich plasma with the idea that what you're going from one mechanism of action to a different mechanism of action. And hopefully what we're seeing is that we then get a more complete therapeutic outcome.
And you're piggybacking on a partial positive, so you're not just going to the PRP before. Yeah, you have more data. That makes sense.
That's sort of the way I handle it. And then after that, once again, what you're doing there is you're dealing with ligament integrity. That doesn't change neuromuscular function, so it doesn't change strength. And so motor control. Yeah. So once you have got improvement in your ligament stability or integrity, and every time you contract your transverse abdominis and your pelvic floor, everything's not wobbling all over the place.
Right.
Then you go on and you get a better effect out of your
conservative management in your rehab. Yep. Just like we talked about on the last episode.
So prior to going on to this, I will have gone through a diagnostic process. I'll be running the hypothesis that this is sacroiliac joint dysfunction. We'll do a diagnostic block. So we'll be looking for the pain to go away on the day and come back. So we'll only be using local anesthetic in this setting. I'll also have patients wear a sacroiliac joint belt or sacroiliac joint shorts. So in that setting, I will have tried it in the rooms. Hopefully patients go, yes, that makes me feel better. It's amazing when we get like the hallelujah moment where someone stands up and goes, what have you done? And like, I'm like, okay, good. We're in the right spot. We're going in the right
position to recruit. It's amazing.
Yeah. So we then put those two pieces of information together.
Yeah.
Has the diagnostic block work? Yes. So that means the pain's coming from the sacroiliac joints. Does the sacroiliac joint belt decrease your symptoms? Yes.
Yeah.
Okay. So now we've
Right.
got these
Two
two
things that confirm.
things that
Yeah.
are then, okay, this is sacroiliac joint dysfunction, is justified to go on and then do a series of injections. And
Right.
then, back to your friend in the neighborhood physio. So in the setting of you've got somebody where you've done a diagnostic block and the sacroiliac joint belt doesn't work, well, then what you're talking about is probably arthritic. And so
Less
then you're going to,
instability, more arthritic.
so you don't have an instability issue, so
Yeah.
you're going on, but it's a pain issue. So this is an osteoarthritis
Right.
issue. So you're going on to the radio frequency within that setting. And then in the patient where you put the belt on and they get worse,
Yeah,
there's one
more
of
impacted.
two things that are going on in that setting. One, the sacroiliac joint might be impacted. So in that setting, as you just said, as people would have known before, sacroiliac joints are flat joints that kind of interlock. And if they move out of whack, they can rotate out of tack and then they impact.
Yeah, and then the belt is pushing them more
and then
together.
You
it's
squeeze them
smushing
together,
effect.
the belt together, and surprise, surprise, it gets worse.
Yeah.
So that's one reason. The other reason why people seem to get more pain when using the belt is due to discogenic pain. And so,
so an additional thing.
That's so if you've got, and that's one of the things, if I'm at times trying to tease out, is this their disc or is this their SIJs? We try the sacroiliac joint belt, do the block. If belt makes them worse, because they'll go, belt makes it worse. I'll use it for 2 days and I chucked it out. Right. And the diagnostic block is negative. Okay, well, then I'm going to head towards disc as in my diagnostic algorithm.
Yeah. So even it excluding things or not being helpful can be very helpful, because then you've narrowed the diagnosis to something else and you pivot.
So when we're doing sacroiliac joint prolotherapy, there's a couple of risks. So the usual ones: infection, bleeding, bruising. You get a bit sore afterwards because they're triggering off an inflammatory response.
Yeah. Short-term, more pain.
We ask patients not to take any anti-inflammatories during the period of time of the therapy and then 6 to 8 weeks afterwards. So that's a bit of a struggle for some people. If you really want to turn it off, take some anti-inflammatories. It turns it off really, really quickly. So it's quite surprising how you can reverse out the effect of the Prolo. The other risk is you can get subluxation of the joint. So particularly in the first, say, 3 to 4 days, what you've got is the joint's already loose. I've done an injection. I've created some pain. So that's turned off the muscles stabilizing the joint. And I've pushed in a bunch of fluid. So like in that sort of setting, you've actually got a short period of time where the joint's actually more unstable. So that's when I ask all my patients to make sure, bring your sacroiliac joint belt, wear your shorts, make sure you're doing it for the first 4 to 5 days afterwards. If it moves, okay, it's like dislocating a shoulder. Okay, the way you've got to manage that issue is that if it moves, we just got to get it put back in place.
Move it back.
Move it back. So then you just need to talk to your friendly neighborhood physio, chiro, osteo that is capable of manipulating. Yeah. And you mentioned him. So I use
Con is famous.
My very long-term friend, Con Tran, who
also a great name. Great.
Yeah. And I will call him and go, please fix my friend, and he'll go send him down. And so he sorts them out. So that is this. Now, the people that are more likely to sublux are those who have had issues with subluxation before. So I think that you don't really see it in patients that have never subluxed, but those who have had subluxations before, they're the ones that you go on to.
It makes sense. Even with shoulder dislocations, if you've dislocated it once or twice, you're more likely to.
It's real, but it's very treatable.
Manage it smart, and you'll minimize the risk further.
Don't sit at home and suck it up. I have patients that sit at home and go, it's really, really sore.
Really
just call me.
It's like so much worse. It's the weirdest thing.
So don't sit at home if it's terrible, and suck it up. Give us a call, and we'll sort all that stuff out. So
so Prolo is one of those where you are, as a patient, going to have increased pain and some of that discomfort short term, but hopefully it's worth it long term as that ligament integrity gets better, and then you can start to recruit properly and you're out of that weakness spasm cycle. that you get stuck in.
So that's
awesome.
it. I suppose the last question there is then, what do you do if it doesn't work? And so I think we published some data a number of years ago. I think that you can summarize into, these aren't the exact numbers, but the easiest way that I remember the numbers are 40% of patients respond and don't need anything further. 30% of people respond and don't care anymore. And so they're like, I'm good.
They responded enough.
They responded enough. Thanks very much. See you later. And so they go away, do their rehab. And so that's where we're good. 20% of patients go on and need to do more. So that's our group that we do 3 injections. And then you're like, okay, you're getting better, but you're not 100% there. Great. We go on to do an extra 2. And then we've got, I quote the number at 10%, but it's not 10%, but 10% don't respond. And so that's that group that's going on to do either a fusion or look at some other strategies outside of that. So
yeah, it's a pretty good split though, all things considered. Because again, by the time
it's
you get
about
to Prolo,
the numbers aren't exactly that, but that's the easiest way. If I remember, it's like 39% and blah and blah. Anyway, whatever.
Yeah,
40%.
Close enough. All right. Yeah, no, that's a really interesting therapy. I think that'll be a good episode for folks. We have a lot of people listening of hypermobility and some of these other disorders that sometimes you end up in this boat with. So
the other questions asked is, how long does it last?
Yeah.
And so I think that's an interesting question. And so I think that you can get sacroiliac joint dysfunction for so many different reasons. I think that the ones I see it mostly for, the hypermobile patient that is effectively, well, we think that they're breaking themselves down. So it looks like that the hypermobile EDS patient, what you've got there is that they have a set of enzymes breaking down the ligaments. And so it's going to then depend on how rapidly you're breaking down. So I suppose, so what I see with those patients, we see patients get between, at shortest period of time, I think you're looking at 6 months. Longest period of time, 3 to 4 years. Wow. Most average, I think you're seeing like that set of patients that are hypermobile getting about 2 years plus out of the therapy. And then they come back and we then repeat it again. The repeats in that setting will depend on how bad they are. So if they're, you come back, your pain's now 8 to 9 out of 10. Okay.
Right. Are you like all the way back to square one, or are you just shifting the wrong direction? Yeah.
So in that setting, we'll go through another 3. But what I'm trying to do with patients now, that if we know that we see that you get about 2 years out of it, we do a recall at about that, 20-month mark, get someone to come in before everything gets that final stretch, do a single injection instead of 3. And so we try and stop that cycle of stretch, pain, weakness, stretch,
inhibition,
pain, weakness,
more stretch,
blah, 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 blah.
Yeah.
For those patients that have got a degree of instability that are not hypermobile, and there's a number of reasons that takes place, falling over, land on your bum, fall off a horse.
I love Dan's example always, fell off a horse. And I'm like,
mate, do you know how many horse people I see?
Australian. No.
Mate, they all and they all go back to riding horses.
One of my patients
all
is
my
Australian.
Horse people. I know you listen.
My horse people are all Australian. That's why I laugh, because I'm like, the horse people are not American. The horse people are foreign.
Yeah,
local travelers.
All my horse people, when they fall off, you land on your bum.
Yeah,
it's interesting, the technique. I hadn't thought about
can you fall better?
The mechanism of falling off a horse, but it results in landing on your bum a lot. And anyway, that setting where you've had a traumatic event and you've effectively unlocked it, a lot of time you can treat that once and you don't need to treat it again. So you just get it stable again.
Yeah, because you don't have this ongoing degradation.
Yeah, you don't have an ongoing issue. So it can be a one and done, or 3 injection series and done process is what I hope for most people. So there we go.
Nice. Very helpful. Thanks, Dan.
That's Prolo.
Solid. All right. I hope we made this therapy less voodoo-like and weird, because it's pretty cool. But same ideas with all these other things. Has to be the right patient that you're doing it in to get the most out of it, and then it can certainly be worth it. So it's important to keep in mind. All right. Okay. Cool. All right. We will see you guys next time on It's Not in Your Head podcast. Take care.
Cheers. Bye. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.